It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
There is great worry these days that the healthcare system in Vermont is completely unsustainable. One expert predicts most of the 14 hospitals will be hemorrhaging financially within just a few years unless major changes are made. In this edition of 802 News, I spoke with Owen Foster, the head of the Green Mountain Care Board, about consultant Dr. Bruce Harmory's analysis and why significant reforms are urgently needed. First, a word from our sponsor. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. You read about what's going on in the healthcare system in Vermont, and people say the system is broken. It almost seems like it's beyond that. I mean, you've got double-digit increases 3 years in a row for some insurance policies. This report that your board just put out where you've got by 2028, 13 of the 14 hospitals will be in the red. You yourself couldn't even find a primary care doctor. It just really sounds beyond broken.
There are bright spots, and I think you're right, though. Big picture, this is an unacceptable healthcare system. We need to fix the healthcare system. It's unacceptable that people in Chittenden County can't get a primary care doctor. The financials are broken. There's no question. We pay some of the highest rates in the country, and we're going up the fastest. And meanwhile, if you do look at insurance companies, if you look at hospitals, if you look at non-hospital providers, they're all financially really strained. So you can't pay the most, not be able to get to the doctor, and everyone you're paying is financially have real solvency issues.
How did we get here?
I'd say a multitude of things. One, some of our problems are not unique to Vermont. Rural hospital closures have been rampant for the last decade, and we in Vermont have that experience too. Luckily, we actually have not had a hospital closure. We had a bankruptcy, not a closure, and now we are looking at what's going to happen in the next 5 years, and I believe that bankruptcies will happen if we do not change. So that's number one. It's not just Vermont. But Vermont's problems are particularly acute, and I would say that's because we have largely a very hospital-centric care delivery system. By that I mean a huge majority of our care has to be delivered at hospitals because we don't have the infrastructure in the healthcare system surrounding and supporting the hospitals. That means a lot of care backs up into hospitals, and that's a really expensive place. They don't want to have to provide some of that care because it's not the right place for patients, and it's expensive, and they lose money. The other big one is really demographics.
Right.
It really is. An aging population pays less for health care than younger people on commercial insurance, and we have a dramatic workforce challenge.
That seemed to be, I talked to Dr. Leffler, who runs the UVM Medical Center, and he really pointed to this demographic and how people who are 60 to 64 just consume a lot more health care. And, you know, one of the things that you talk about in the reports that the Green Mountain Care Board has put out is things like we need more affordable housing. And I'm thinking to myself, wow, you know, if that's really kind of the underpinning of what needs to happen for healthcare reform to happen, you know, God help us.
I mean, that's certainly true, right? You can't wave a magic wand through healthcare policy and fix demographics or fix the housing costs. That's just beyond the healthcare realm. But there are things we can do in healthcare specifically that will help with that. On the hospital side, you want to be able to manage a hospital to Medicare. That means your finances need to be solvent if you just get paid what Medicare gets paid. And according to MedPAC, the federal folks, they would tell you that an efficiently run hospital can make money on Medicare or about break even. Our hospitals are far away from that. So we need to be able to move our hospital system to be able to manage to Medicare. And then beyond that, we need to make sure that all these other supports around the hospitals are solvent and adequately funded. Our FQHCs, our mental health, our long-term care, because not having those backs up in the hospital.
Tell me more about what you mean by the getting paid, the Medicare part of this.
Right. So,
and why aren't we getting that?
So Medicaid, Medicare, and commercial are the three big buckets of payers. In Vermont, most hospitals are making 55 to 60-ish% of the care costs on Medicaid. So if you go in and you're a Medicaid patient, the hospital will receive, call it 60% of what needs to be paid to cover that care. The doctors, the nurses, the supplies, everything. Medicare in Vermont is probably around 65 to 75%. And then commercial is extremely high, making up the gap. And so the point is that we need to be able to run on the Medicare amount and not have to rely so heavily on commercial. The reason for that is, one, we have a dwindling commercial market, so it's not sustainable. There are not enough of those people paying that amount, and it's actually getting smaller. So as it gets smaller, the amount they have to pay is more, which is then the spiral into affordability in the state.
How can you change that?
We are trying to require it and take steps in that direction through the regulatory process. We are saying you are not going to be bailed out commercially. You need to make sure your operations can run on this. And some of that is doing what the state's been trying to do, which is population health. You need to make sure the patients are going to the right places, not backing into hospitals, or you need to make sure your preventative health care that you have at your hospital is working well. Or for like a UVM, a bigger operation with a population health services organization and an ACO, those are designed to do this. We need to see them work. They can't just be expensive things without having the fruit from it.
How long have Vermont hospitals been losing money?
Many of them have had bad years here and there. I'd say directionally as a group, the last 5 years have been pretty rough since about 2018, 2019. There've been some blips in there where you got COVID funding and some, I call it bailout funding, that made things better. But the trajectory since 2019 has been predominantly downward, significantly.
Okay, what changed in 2019?
I'm not sure I could point to one thing specifically, but really it was just the economics of hospitals nationwide, the costs to run a hospital. We have 14 hospitals in the state with a lot of overlapping services. The infrastructure costs are high. The workforce costs are high.
I was mentioning that by 2028, your consultant says that 13 out of 14 will be losing money. But there's this talk about cumulative losses, and that by 2028, just if you were to have hospitals break even, we'd have to come up with $2.4 billion. If they had an operating margin of 3%, $3.1 billion. That's a lot of money.
There's no way we can come close to it. There's no way the state can come up with that money. Now, projections are projections, and that was based on a growth rate of, I think, 3.5% and an expense rate of 5 to 7%.
Right.
So those things can change, and that's what I was talking about with the managed to Medicare. We're trying to get that operating expense growth down more around an inflationary level. That's part of our problem in Vermont is our expense growth at hospitals has been enormous. So I think I'm a little off on the exact numbers, but UVM has been around 15, 9, 8% the last three, or maybe 22, 23, 24, somewhere around there. Not precise, a little, but directionally, that's really high. That means you have to get more money to cover those costs. So we need to make sure the expense growth is controlled to what we can afford.
Okay. What's driving the expenses? Let's stick with UVM for a moment.
It's a huge operation, right? So there's any different number of factors, but a couple that stick out and jump out in their budgets we just did are the traveler costs, the cost of traveling nurses and the workforce. If you have a high reliance on travelers, it's enormously expensive and it can impact the quality of the care that is received. And culturally, it can have an impact. No nurse likes to sit next to somebody else who's making double or triple for the same work who then leaves in 3 months. It's not productive. So that's tens of billions of dollars a year. And UVM has historically been way over national academic medical centers in terms of how heavy the reliance is on travelers. So we need to get that under control.
Well, okay, and that I watched the hearing that Senator Bernie Sanders put together that you and some of the other, I'd say the big players in healthcare here in Vermont, and Dr. Leffler of UVM talked about how that peaked out at about 125 million a year. It's now down to 75 million a year, and that those are big numbers, but in an operation that's about $2 billion a year, it doesn't sound like there's an enormous amount of savings there.
I mean, that's a big driver. There are many, right? I mean, there's significant money expended on the PHSO, the Population Health Services Organization. I think that's up to about $30 million a year. And so what I said earlier about making sure that these investments are paying off, that's part of it. There's a lot of expenditure into the IT, into revenue cycle, right? And the IT was meant to increase billing and accuracy and patient safety and all of those things. So we need to make sure that those investments are paying off. Another big one for the medical center or the network is the investment in the network. That's supposed to bring synergies and economies of scale and efficiencies. Are we getting that as a state? And how can we help support UVM in making sure that that's pulling through? So we're kind of at a point where the money has been spent and now we need to make sure it's working.
Well, one of the things that I remember happened was that when it was Fletcher Allen, which is now UVM, was allowed to merge, affiliate, I don't know what the correct verb is, with the hospital down in Middlebury and also in central Vermont. And I think it was billed and sold as this method that was going to save all of us a lot of money by merging these services together. Did that happen?
We have asked for information on that, and I don't think we've seen it. I don't think we've seen those economies of scale. The expense growth at the network has been quite high. And that's not to blame them, it just is. And that means that hopefully there's still opportunity to realize some of those and to think about why we're not getting them and to make sure we are. So those hospitals cost different amounts for commercial, right? They're very different hospitals. You're talking about Porter, CVMC, and UVM. There is opportunity for UVM, if they're full of capacity, to send patients to CVMC, and they do that. There is opportunity where, if there's particular services that can be done more affordably at Middlebury and there's openings, you can do that. So making sure that power of the network is working at its optimal level is something that we want to make sure is happening.
Okay, but and we're here in Burlington, so if I have a condition and I'm sent up to the hospital here, I'm going to want to stay here.
Yeah, and there's patient choice across the state, but they might not have availability here, or they might have a better physician for that particular service in Middlebury, right? So sometimes a patient might need to go other places because it's where you can get in and where the best doctor is for your situation.
And I want to explore this a little bit more in a moment about this idea of having different hospitals do different services than what we've typically seen, where a hospital kind of has all services available for all things. Mm-hmm. But, one of the things that I'm maybe it's me, that I'm just not understanding is that when you talk about a hospital and trying to, quote unquote, cut their costs, if you own a restaurant in downtown Burlington and your expenses are too high, that you can say, well, we're not going to have lunch and dinner on Monday and maybe even Tuesday. You save on staffing, you save on costs for your product. You may even cut your menu from 8 entrees down to 4. But a hospital doesn't run that way, right?
No, they don't. But you have to keep in mind that if you stop serving lunch, maybe now you can have brunch on Sunday. Or instead of serving foie gras, you can have some meat and potatoes 7 days a week, right? And so it's not just subtraction. When people see a report like this and recommendations, it's natural to see there's a recommendation that we don't do this and we don't do this. Two things. One, some of these service levels aren't being done at high volumes. So you have proficiency concerns. Are they being done enough so that the physicians and the team helping the physician, supporting, doing it with them, are doing it safely, right? So there's a volume thing. The second piece is that you're actually recommending that we add a lot of things. And that's the important piece to the report that a lot of people might not initially see. I couldn't get a primary care provider. There's many people that I know that can't and call me and say,
Yeah.
what do I do?
Yeah.
So yes, you might be saying maybe you don't have brunch on Tuesday, but you got breakfast on Tuesday, right? And you need to make sure you have all of those services: mental health, long-term care, primary care. Because if you don't have those, you're really in trouble. And long-term care is going to be a big problem in this state very soon, if it is not already.
Well, let's start with the primary care. Why do you think you had such a difficult time? I recall you saying, I think you went to 8 different places and couldn't get a primary care. And all I could think to myself watching this was, oh my God, if the guy who's running the Greenmount Care Board can't find a primary care doctor, God help the rest of us.
So I should not get any special treatment, and I don't. But
Fair enough.
My position was the chair of the care board. So what happened was I had I think it was a PA maybe 8 years ago. They left, and then I tried to get a doctor for a period of years, and I couldn't. And fortunately, I've had good health, and I just gave up. When I became the chair of the care board, we had a number of meetings with primary care physicians, and people were talking about this issue. So one afternoon, I decided I should see if I can get a doctor. And so it might have been 7, it might have been 8, it was 7 or 8, is basically everyone in Chittenden County I could call. And I could not even get on a defined wait list. Nothing. And I would ask them why, and they would say that they just don't have any availability. The panels are full, and they're not taking new patients. I guess your question was, what's the reason for that? I think there are opportunities to see more patients in some of these panels. So nationally, I think Dr. Harmory spoke about, you need to see 3 patients an hour instead of 2.
That's 20 minutes apiece. Okay. Yep.
Right. But there are ways that practices manage that. So you'll actually manage the panel so that patients that are just a quick wellness check, a quick simple check, will be, a number of those in an hour, and then you'll have someone for a full physical, and that might take longer, or somebody with so you manage the panel and the scheduling so that you can do that and you don't have these backlogs.
Okay. Did you ever find a primary care doctor?
I did. I had a tick bite, and I called a nurse friend of mine, and they had a cancellation, and they got me in, and I do now have a doctor.
Wow. And you did not get Lyme disease?
No, I did not.
Okay.
Luckily.
Congratulations. But so go back here to my what possibly is a poor analogy with the restaurant. You can save money at a hospital, and Steve Loeffler, the head of UVM, made this point. You can close down beds, you can close off wings, you can close off departments, but that might mean that you and I don't get the care that we need. How do you respond to that?
You're not just going to close down things that shouldn't be closed down. And the care board is not closing down anything. This report was an opportunity for hospitals in the state to recognize what the future looks like, and for a international expert to give us options on how to best handle that. So, people do take it as, you're closing it down, I don't like that. The reality is it's going to be closed down if they're bankrupt. It's not a choice. It's something we have to manage and address and not ignore. And when you recommend closing down something, you need to be strategic and smart about it. Are you closing down mental health in the throes of a mental health crisis? No, you're not going to do that. Are you going to close down primary care when people can't? No, you're not going to do that. Are you going to recommend that, if there's somebody down the road that can do the surgery and is doing the surgery and has capacity and is a gold star doctor at doing it, and you have low volumes? Yes, you might, because that gives you an opportunity to ensure that the other place doesn't close and that you have greater efficiencies in your system, right? So I think and can you add mental health to that array of services? It's making sure we have the right balance of services. No one wants to change or close anything. I don't either. I also don't want to not have mental health or primary care in this state.
So give me sort of the vision here. Is it that there would be one hospital that would focus on mental health, another place to do orthopedics, another might be a pediatric center? I mean, what would the 14 hospital system look like here in Vermont by the time you get done with the reform you're talking about?
So one, the reform is not being done by the care board. It's being led by the Agency of Human Services. And second, it's actually the initial decisions are all being made locally with help and assistance from AHS, right? So no one's doing this. It's local decisions with guidance from the state. How would you allocate the resources? That was a big part of Dr. Harmory's recommendation. So instead of having, I'm off on the number, but 12 places that do orthopedics, some with low volumes, some with capacity to do more, some that are really excellent at it, some that just don't do enough. You would have centers of excellence geographically, strategically located across the state so that there aren't problems with travel and disparities and that kind of issue. So there are different types of services that the Harmory report recommends are in particular strategic intelligent places to ensure access without the overlap and the cost structure that we currently have.
Okay. So would every hospital under this stay open in some capacity?
Yes, there was no recommendation for any closures at all. I think the most, I guess I'll call them serious recommendations were for hospitals that Dr. Harmory considered in real financial jeopardy. Those are Grace Cottage, Gifford, Springfield for sure, and also North Country, and Copley has some financial challenges as well. And when I talk about that, we're talking about like the days cash on hand. You want hospitals really 120, 130, 180 days. A number of these hospitals are already under 100 and trending downward after years of very large commercial rate increases. So the math won't work unless you do something different. I think there's a recommendation to add Jerry Psych at Springfield or to add urgent care. There's a shortage of urgent care. Rehab, yes. The answer is yes. Every single hospital would stay open under the Harmory recommendations. Some of the inpatient components only at Gifford, Grace, and Springfield under Dr. Harmory's recommendations would be closed. Keep in mind, the volumes at those hospitals for inpatient are quite low. They're largely outpatient services currently.
Okay. So when the report came out, there seemed to be, or there was, a lot of pushback from some of these smaller hospitals in smaller communities, places like Gifford down in Randolph, where people kind of went, oh my God, this is the lifeblood of our economy. Were they wrong in that assessment?
No. I mean, I think look, you should fight for your hospital and make every argument that this is not correct. I actually think you make better decisions when you have the full spectrum of voices. And my point is you have to hear both sides. And so having really vigorous discussions and challenges to the recommendations is probably one of the best things we can do. Ultimately, I believe the Harmory recommendations, many of them, I don't agree with everyone myself, are correct. And directionally, they're entirely correct. So if a hospital chooses not to make changes, they're taking a risk that their projections and hopes are wrong. And if they're wrong, then they are going to have financial problems. And so the point is to get ahead of this and to do it intelligently and strategically. I know hospitals are pushing back and communities are pushing back. They are the lifeblood of some of those communities. And that's why we need them to stay open and not have that problem in the future.
How do you get communities, how do you get the hospital, particularly the hospital leaders, to kind of get, and I'm moving my hands across the table here, from here to there, and understand that the options are even worse if they don't? How do you get people on board with this?
That will be AHS's leadership in leading the transformation. And the Care Board will be collaborating with AHS in that effort. But I think the first thing is to have frank discussions. There's a process. You listen. You go back and forth. And that happened throughout this entirety of this before Harmory's recommendations came out, right? We had this huge community engagement process where we went into every single health service area and presented a lot of the information we were seeing. There's a ton of feedback. Thousands of people were met with hundreds of meetings, right? So that's to make sure that the information was really fully informed, the decisions were fully informed. And then now there's another process again of people now having to digest this and think about that. And sometimes with time, you first react to anything, it's emotional and you want to challenge it and fight it. But over time, you start to recognize, hey, maybe this is right or maybe this is wrong and I'm going to go with this. I agree with this one. I can do this, right? And we're already seeing that. A lot of hospitals, even before the report came out, were taking a lot of steps to address some of this. So Northwestern, Copley, Brattleboro, they formed the New England Health Collaborative to start trying to synergize their expenses to work together to lower their costs. North Country and Northeastern, they're sharing some physicians and services. And so it's already happening, and that's really a great thing. So just by doing this, everyone's working together to make some steps.
I'm thinking to myself, though, the comments that you heard prior to the report coming out, people react to something that's more definitive, and they're thinking, well, if I'm living in Brattleboro, it's fine if they cut the Newport hospital, but if you're actually talking about my hospital, well, wait a minute.
That's very human and normal.
Yeah,
and we certainly see that.
Yeah. So, do you really feel that the input you got prior to this report coming out really had any value?
Tons. I went to a lot of the community meetings, tons. I think just for people being aware of the situation was immensely valuable. And for people giving feedback as to what services they really were missing. I can't get this. I can't get this. We need this. That drove a lot of the recommendations about what to add. And also, hey, we need this more than you think for these reasons, right? There's local knowledge that the state or Dr. Harmory may not have. That's why we were so embedded in the communities. So no, critically, I loved it. I thought it was so valuable.
What did you said that there were parts of the report you didn't agree with? Give me an example.
I should have said that. Good question. So there are some that will be harder to do than overnight. So I'm just thinking directly about the Care Board recommendations. They made recommendations for us as to how we need to change. One of them was to move hospitals to 200% of Medicare through a reference-based pricing policy change. I agree with the recommendation. The issue for me is that takes a lot of time. Some of our hospitals are well over 300% of Medicare.
I don't understand what you're talking about, so you got to help me on this.
Yep. So if Medicare, we spoke earlier about a hospital should be able to run on Medicare.
Mm-hmm.
So that would be 100% of Medicare is 100.
Reimbursement. Okay. Yep.
And if your commercial prices are double Medicare, let's say Medicare pays $100 for the service, 200% would be $200. 300% would be $300 for the same service that Medicare pays $100.
Okay.
So the reference-based pricing mechanism has been used in other states to lower healthcare costs quite effectively. And so what you're trying to do is get everyone to a reasonable commercial cost. The services are paid as a percentage of Medicare. So currently, if we pay 300%, Dr. Harmory's recommendation is you should only be paying 200%. And I agree with the sentiment. Moving down to 200 would be disruptive because our hospitals are very, very high commercially, and it would take time to do that. So I just think that it is something that needs to be implemented over a period of years and thoughtfully, not very quickly. Not that he said very quickly, but I think it could be read that way.
All right.
I also think that,
Sorry, go ahead.
North Country Hospital is a different hospital. It's up in Newport. It's very isolated. They've had some leadership changes, and they've had pretty good results the last couple of years. They're on a better track. So I think there's some, and they're hugely Medicaid dependent, right? Their Medicaid payers there's more of those patients. So that hospital is a little bit different to me than some of the others.
So there's no one approach for all 14 hospitals?
Not at all.
And who's going to, is it AHS that's going to make those decisions, or how is that process going to work?
So the legislature didn't set out a specific who's going to do what in Act 167, which led to all this report. They passed Act 51 in 2023 that put AHS in the lead of transformation, but it didn't empower AHS to close this service, close that service. So it's really intended to be more of a collaborative process where AHS works with hospitals to drive the transformation.
It sounds from what you just described to me, and maybe I completely misunderstood it, that if you get everybody to pay Medicaid rates, there will actually be less revenue coming into a hospital.
Medicare rates, Medicaid rates would be way too little.
Okay, Medicare, sorry.
Yeah.
Yep.
Significantly less money for Vermont hospitals if everyone paid Medicare rates, significantly less.
Okay, so they would have to make dramatic cuts.
Not necessarily. I mean, yes is the short answer, but there are other ways to manage it, right? So there's so many places hospitals spend money. You can, improve population health and you don't need to make cuts. If you can keep your population healthier, you don't need to make the same cuts. If you can increase your clinical productivity, the efficiency of your operations, you don't need to make cuts. That was a big piece of this year's budget review. Many hospitals in Vermont have very low clinical productivity and efficiency, which means they're not seeing a lot of patients. Some because of where they're located and because of the volumes, others for operational issues or staffing issues or whatever they might be. So you don't need to make cuts if you can see more patients with what you have. It's about optimizing what we have because we've spent all the money and now we need to make sure it's working. I mean, we pay as much really as anywhere in the country for healthcare, but we're not optimizing the usage of it.
Because what I'm hearing in that is that if you've got by 2028, 13 out of 14 hospitals are going to be losing money, if they have less revenue coming in, you're just going to make that $2.4 billion to $3.1 billion problem bigger.
No, because the projection of that hole was based on a 3.5% growth.
Okay.
Right. So the hole will be bigger if you don't control the expenses, yes.
Okay.
Yeah.
So you're talking about you're talking about cutting the expenses down to like a 0% increase over today, or what are you talking about?
I think it would be...
Or negative?
Well, it depends on what you're talking about. Revenue, commercial,
I'm talking about overall revenue.
Overall. So I think that the goal of the all-payer model and to have a sustainable system, it has to be an affordable system. And that would be more around an inflationary level increase. I'm not talking about giving hospitals no money. You would ruin healthcare. But if you're increasing costs 10%, 15%, 20% a year, you're also hurting patients because they can't go to a doctor or they can't buy insurance. And we're talking about just hospitals. If you don't give money to the other parts of the system, you're also hurting hospitals, hurting patients, and hurting all those other providers. Some of these discussions get isolated on hospitals, and you have to think about the whole system. So if we give 20% to the hospitals, Blue Cross might go bankrupt. If we give 20% to the hospitals, that independent down the street who sees 4 patients an hour might go bankrupt. Or community health centers, which is having serious financial trouble, might go bankrupt. So yes, you are going to reduce revenue and commercial costs that are going to a hospital, but part of it's to making sure that you have a well-functioning supportive system around it. Our problem in part is that we don't have that already. So you have to balance that, and that's the intent of all of this.
Well, as we talked about before, one of the key parts of this, one of the key players in this is the whole primary care physician world. How do you bolster the number of primary care physicians when it's a whole lot more appealing for me, having a lot of medical debt, to become an orthopedic surgeon, cardiac surgeon, or work in one of these more lucrative fields?
Yeah, that's part of the problem. We need to pay them differently, right? They shouldn't be making half or less than half than some of those specialists you talked about. That's not good for a population health perspective. So we need to make sure they're being paid adequately. And part of that is when we set hospital budgets, what are the consequences collaterally to all those primary care providers at Evergreen or Richmond or wherever you are throughout the state? We don't want them going bankrupt either. So just being more holistic in our thinking has been something the board's been trying really hard to do. And there's a couple things the state has done that should make it more attractive for primary care. One is the prior auth bill that was passed last year. Primary care does not have to get prior auths anymore in Vermont from insurance companies. That lowers the administrative burden. The other one that needs to be thought about is some of our healthcare reforms. Some of them are federal, some are ours. What kind of administrative burden is that putting on small practices? They can't handle it. So you want to remove some of the more challenging aspects, the administrative aspects for these primary care providers, so they can just see the patients and they don't have to work and stare at the EMR and handle all of the MIPS reporting or whatever it might be.
One of the other parts of this is people being able to afford to live here in Vermont. One of the reasons why there's so many traveling nurses, I think the nurses union administrators would say, is because you can't live here in Vermont. So, it just seems like there's so many different parts of this puzzle that all need to come together kind of perfectly and more quickly than is realistically possible. This state's not going to all of a sudden build a ton of affordable housing that isn't going to just get gobbled up by all these people who want to move to Vermont anyway. Solve that problem for me.
I don't think the fact that there's no solution that's readily available means you don't do anything. You take what you can and you do what you can, right? So I'm looking at some of the recommendations of the Care Board. We're not going to fix healthcare regulation in a year, but we're going to take those recommendations and start working on them really earnestly. When I got to the Care Board, one of the things that struck me was we need to think more holistically about the system. You get a hospital budget, but it has so many collateral consequences. Let's make sure we're informing ourselves about the broader system, even though we don't manage the rest of the system. Mm-hmm. It's all interdependent. So even though there's no silver bullet, and there's not, you still have to start tackling the problems that you can. And some of them are addressed in the Harmory report, which is, do we need this service? Are we costing ourselves this service because we have 3 of this service? And making sure that we have those. It's not fair to the people to not be able to get a primary care provider. It's not good for health. And it's not good for costs. You talked about reducing hospital revenue because you don't give them the commercial money. Every time you increase commercial rates by 20 or 25%, you make it harder to recruit those families that you want to come here. So you can't do that. You have to balance it.
You also, in this, Harmory in this report also talks about what I would call waste. Maybe there's a nicer term for it than that. And the number that I'm remembering is about $400 million. Where is the waste in the system?
I don't agree with the word waste. Some of it can be inefficiency.
Or excess, yeah.
Right. So some of it might be service lines that are underutilized that cost a lot of money, right? So Harmory spoke quite a bit about, the call schedules are such that if you have a service, you can't have 1 doc or 2 doc. You need 4 docs for that service. If that service is very underutilized and is available 30 minutes up 89, and it's something that's not emergent care, is that an opportunity to reduce cost? Another one might be ED visits, right? That was a big number in his report. There's so many ED visits that are, quote, avoidable. And what that means is those patients should be seen in primary care. A better place for them to go, quicker, and it's way more affordable. A lot of hospitals this last year testified about their EDs having tons of patients that should just be in primary care. So it's not necessarily waste, it's having the right resources available to patients so that they don't go to the ED because they can't get to a primary care doc.
Okay, can you give me an example or two of that where there's a service that should be done 30 minutes up the road?
Well, it depends on what they are, but certainly you could do it with orthopedics. Orthopedics is a scheduled surgery, mm-hmm. right? And do you want orthopedics in 4 places within an hour and a half of each other, each one being 30 minutes away or so? I'm making up, I don't have the exact geography mm-hmm. in my head. But you can go 20 minutes to one or you can go 30 minutes to the other. Do you want 16 doctors to provide that service in that area at an enormous cost and also keep in mind all the infrastructure? Or should you have it centrally located where it's really done well? That would be an example. Elective things, right? Things you can schedule. Certainly, emergent care would not be one of those things.
Okay. Because for example, I hear, because I'm getting a little bit older, people, if you want orthopedic surgery, Copley is really good at that. They've got a shoulder guy or a knee guy or whatever it is that's really good. Is that already happening naturally?
It is, for sure. My father got injured this year skiing, and he went to Copley. He had tremendous care. He can't stop raving about it. And if he hears I didn't give them their budget, he calls me and tells me I should give them their budget. And
you kind of hammered them. Actually, their budget request was cut more than any other hospital, from what I could tell.
They got the biggest NPR in the state, so I don't think so. I don't think we hammered them at all. I think they got the most NPR, I think, in the whole state.
I don't know what that term means. But
revenue.
Okay. Because I saw a number that they requested and what you approved seemed to be significantly lower.
So every year we put out guidance, and the guidance is based on really inflationary factors. And then the budgets are evaluated consistent with that guidance based on all these various factors: quality of healthcare, the cost of the healthcare, your clinical productivity, all of those things. And this year, if your clinical productivity was low, you were not going to receive, it was unlikely you'd be able to hit your burden to get a higher rate. I don't look at it in terms of necessarily like what did they ask for and what did they get? I compare it really more, what was the guidance and did you give them more than guidance? And in that context, Copley did very, very well.
So why did they think they needed so much more and you didn't?
I have 14 hospital budgets in my head, so that I haven't reread Copley in probably about a week. But certainly the clinical efficiency across the board in the entire state was one of the things we focused on. And if I remember correctly, I don't think any hospitals had high clinical productivity levels. So that would be probably one of the main drivers.
You know, it's funny you say this because what I hear from people is that you go to a doctor and, you know, you're in and out of there in 20 minutes and it seems too short a period of time. And it almost sounds like you're trying to push that even harder. Am I mishearing you?
No. So you're talking about, well, from the patient perspective, you're right. But keep in mind, there's a lot of patients who aren't even getting to see the doctor.
Correct.
Right? So you have to consider that part. But the other is, it's from the viewpoint of how many patients is the doctor seeing as compared to peers. So as a doctor, are the doctors working 2 days a week and are they only getting in 5 patients in a day? That would be a low clinical productivity. And that can be for any number of reasons, such as scheduling like we spoke about earlier, or operations, whatever it might be. So we're trying to make sure that the operational efficiencies are really high so the providers can see the patients they need to see.
Okay. So does that mean people have to work more days? They have to see more patients, both, or something else?
Yeah. Seeing more, it can be both. It can be extending the hours of operation for a hospital. It can be doing calls on weekends. So UVM, I think last year, started doing a number of sprints in particular areas where they had wait times, where they would increase the volumes and get more patients through so that the patients weren't waiting. So yeah, there's a number of strategies. You can't make doctors work more days that don't want to. People are part-time. They have research they do. They have other interests, whatever it might be. But it's also making sure the hospital is providing the opportunity for them to be able to do that.
Is there a danger if you do any of these reforms? Because what I don't hear people complain about is quality of care. And, you know, and I guess, thank God, that's not the issue that you're dealing with.
I think it is an issue. I disagree.
Oh, okay.
It's a big issue.
But, I mean, the care that people get, and maybe I am wrong. I mean, what I hear is people say, you know, they had good care, they were successful in getting whatever treated. I mean, there's not a lot of malpractice, I guess maybe is a better way to put it.
Historically, that's true, but we are seeing quality in the state decline.
And how do you measure that? And what do you mean by that?
So there's a number of things that you look at. Medicare has a STARS rating, and a number of some hospitals went down in their STAR ratings. That's a quality and safety rating that Medicare puts out. So those went down. There's a group called the Leapfrog Group that looks at all these hospital-acquired conditions, and they all give out a grade. Grades at Vermont hospitals went down. Then there's also financial penalties that Medicare imposes on hospitals for particular quality and safety issues. And a number of Vermont hospitals had financial penalties last year. And that's concerning. It's not to blame a hospital. There can be many, many reasons. And part of it is, again, going to the system of healthcare that we have. If hospitals can't discharge a patient to long-term care, that patient is in a place where that place is not equipped or really designed to do that. So again, when we go to, hey, you're going to cut the hospital's revenue and hey, you're going to cut a service. Well, yeah, but you're also going to add this service, which will make sure that patients are treated better, more affordably, more appropriately, and that they'll help with the quality, right? So hospital-acquired conditions, that's a problem that a number of hospitals had this year. Some of it can be their protocols and their policies. Some of it can be travelers. Some of it can be any number of those things. But another component of it is having this system.
All right. So looking at this sort of bigger picture, are you talking about that really what needs to happen? Vermont spends about the same amount of money, but spends it in a different way?
Yes.
And that would be on more primary care, more elderly care, less acute emergency room care, that kind of thing.
That kind of thing. Certainly long-term care, mental health, primary care. The other thing is you have to think about our demographics that Harmory spoke about a lot, which is aging, and in certain communities precipitously. And so recognizing what our healthcare needs are going to be. A lot of what we have is sort of by historical precedent, right? But it's not necessarily what's coming down the pike. What do we need for memory care down the road? What do we need for long-term care? And there's I don't know if tsunami is too dramatic of a word, but there's a tsunami of people that are getting much older in this state that are going to need those services. So a big piece of this report is making sure that we have what we need for the future and that it's still there and not in financial disarray.
Well, it just, again, you know more about this than I do. It just doesn't sound like there's enough money in the system to continue to do what we have to do today and do these other things that also have to be done too in order to reform the system.
Right. The things that we're missing cost a lot of money. The long-term care costs a lot of money.
Yeah.
All of these things cost a lot of money. The transportation to make this all work costs a lot of money. The EMS system costs a lot of money. So yeah, we need a lot more money if we're going to have the care we need. What do you do when you have no more money and you have huge care needs for the state? You have to find the money. And the way to find the money is to use it as optimally as you can. And that's what this report is about.
Okay. But is ultimately the system going to need more money to make this happen? Or can you really do it on, it's what, about $7 billion that we spend in total on healthcare? Something
about right, yeah.
Okay.
6.5.
Yes. Is that a big enough pie of money to be able to redivide up a different way?
I think it should be. So what I look at is the per capita healthcare spend.
Okay. Yep.
Healthcare data very often lags by a year or two. But Vermont's per capita spend is top 7 comfortably in the country as of years ago. And we've had big increases since then. So we're probably more tracking top 3, 2, 4, 5, somewhere in there. We're top 5-ish, I'd say, about now. So if we're spending top 5-ish money in the country, aren't we spending enough money? We're a nation that spends the most money on healthcare in the country, and Vermont's one of the most expensive. Some of that's good. You might want to spend more because you get better care. But you got to keep in mind, we don't have a lot of the markers that make the state more expensive for healthcare. What I mean by that is there's virtually no private equity here. There's no for-profit hospital here. And we're one of the healthiest populations in the country. So if you have a really healthy population, should you be the most expensive? And that can kind of go both ways. If you're the cheapest state, are you going to be one of the healthier states? Are we healthy because we spend a ton? I don't know that we are. We have a culture of people exercising, taking care of themselves and their neighbors and eating well, and we have a healthy culture. So I think we do have enough money is a short answer. I can't really imagine being particularly higher without having the negative consequences of people not going to doctors and not affording health care. That is equally detrimental to people as not having a particular service.
It sounds like the big factor here that's working against Vermont is the aging demographic.
Yes.
We're not going to change that.
If we make the state more affordable, it will certainly help. And part of that is making sure our healthcare system is affordable.
And theoretically to attract more younger, healthier people to make this spread out the costs in the system.
Correct. We want more people on commercial insurance to spread out because we want the hospitals and the system to be able to run on Medicare, the Medicare reimbursement rates, and we want more people in the commercial market to spread it out.
Put yourself in the place of somebody running the UVM health network or even just running UVM. What do you think the biggest challenge is going to be for them to institute these kind of reforms you're talking about?
So UVM's recommendations, I don't have them in front of me right now, but there's a couple service lines where there's recommendations to stop doing particular service lines.
Well, they say dialysis they lose just a ton of money on, but obviously we've got to have dialysis or not.
So the losing a ton of money on is a little bit, it's more nuanced than that. A hospital negotiates with insurance companies its rates, and they choose where they put that rate. So there's some volition on where the rate is going. So if you choose to put it on one particular service, like a 40% increase on X service and 0 on another, there's some choice in what you're making a winner and a loser on the commercial side. Now, any hospital has complicated relationships with insurance companies, and some have more market power than others. But generally in Vermont, vis-a-vis Blue Cross, there's pretty good opportunity to put rate where you want it. So you don't necessarily have to, quote, lose money. You can mitigate that how you choose, and you should from a population health perspective. So if we keep a cap on the total revenue growth, it really becomes more pressure to make sure you're increasing and improving population health. Your population of people need to be healthier and staying out of your hospital, or you're going to go over your caps.
Okay, isn't part of this the old pogo thing? I mean, isn't the problem really us? I mean, you talk about healthcare services and systems having more healthy populations. You know this as well as I do. The American public, you know, our diet, whatever. I mean, I'll just stick with diet. I mean, we're, you know, the amount of alcohol. I mean, all the things that we do, we're creating the healthcare problems. It's not, you know, it's not the UVM administrators up there. Isn't the problem ultimately us?
Yeah, I mean, I don't think it's like a blame thing. I mean, Vermont's one of the healthiest populations. So as compared to other states, I would say that we should really pat ourselves on the back for being very healthy. But certainly, yeah, I mean, the social determinants of health really drive a lot of your healthcare costs. So if we have a type 2 diabetes, heavy population, smoking and drinking and not exercising and chronic obesity, our healthcare system will be really, really expensive. But generally speaking, Vermont actually does quite well on those things. Yes, if I could improve population health and have people make better decisions for their own personal lives, that will help the system more than anything.
Would it make more sense, as some people argue, that we scrap the system here and have, instead of the insurance companies and me as a copay, if I go up and get a surgery done, that we don't do fee for service, as it's called, that we just have one big giant budget for the state of Vermont and figure out a way to do it that way?
Anytime you make a big change like that, you're going to have things you didn't expect, right? So we did the all-payer model, and we thought that would be the salvation of our healthcare system, and it was unfair to the all-payer model to have that kind of expectation. There is no change the payment delivery and everything is going to be perfect. No way. I think there is a benefit to a capitated payment. I think it's a really good thing to go towards. There's also a place for fee-for-service, if you ask me, because fee-for-service can drive incentives. You can be incentivized to provide more primary care, right? You can attract people by paying them more money. So you can align incentives with a fee-for-service program. Ultimately, I think that a capitated payment is the right way to go. But under a capitated payment, you have to have a system that functions appropriately and can move patients to the right place. You can't flick a switch and all of a sudden, parts of UVM are a long-term care facility. That's not going to happen. Mm-hmm. You still have to be able to recruit the providers to do that work. But yeah, I think there's a really good place for capitated payments ultimately to help our system.
Remind me, what are capitated payments? What's that term mean?
Yeah, I think you were alluding to a global budget, one large payment for a population of people. Here's your check. You provide all of the care for this population of people for this amount of money. And how you do it and what services you provide are up to you. In contrast to fee-for-service, which is you get $100 for this, $500 for that, and drive volume because you want to make more money. Now, Vermont doesn't really have a utilization problem, but by that I mean we're not seeing too many patients. That's a problem that many other states have. They have too much utilization. They're trying to tamp down utilization to control costs. Ours is the opposite. We have a cost problem, not a utilization problem, although utilization's upticking currently the last couple of years. And so if you give them a global budget, are you actually going to disincentivize getting the patient in the door?
Okay.
So as a lawyer, I'm making up numbers, but if you paid me $1,000 an hour, I would say, oh, that's cool. I'll work 500 hours for the year and make a lot of money. If you pay $100 an hour, you're like, oh, I gotta work 1,500 hours, whatever it might be.
So we're not, as a state, having procedures done that don't need to be done. That's not the problem.
Every state has that to some degree. It doesn't seem like, generally speaking, that's an issue in this state, no.
What's going to be the biggest challenge to make this happen?
Really good question. Honestly, I think politics. Wading into this area and changing things is very hard politically. It's going to be inertia. It's going to be fear. It's going to be status quo bias. It's going to be disputing the data. We've seen this before. Anytime there's big changes, people will dispute the data and say, well, do it this way, and then it's all good. I fear that will happen. It will happen, but I think we'll get through it.
Realistically, how do you take some of the politics out of this?
I think you just have to be realistic about what the alternatives are. And we've already seen a bankruptcy, and you can't dispute the data of hospitals' days cash on hand and margins going down. And you can't dispute the 20% rate increase the Care Board approved. You can't dispute those things. And so I think just being honest and upfront about where we are as a system is the first step. And so, in any healthcare data, people dispute all these little nuances. Mm-hmm. Back up for a minute and say, what have our commercial rate increases been?
Yeah.
And what is the financial situation of the players, Blue Cross, UVM, Springfield, everybody? You can't dispute that. You can't dispute the 20% rate increase. You can't. It's painful for people. You can't dispute the financial positions of the hospitals. And you can't dispute that people are having a hard time getting in. And you can't dispute that Blue Cross was in an incredibly difficult solvency position. So you can dispute any little piece you want. I don't really care. The board is not in a position to approve 20% rate increases. It will be worse for the state. And so we need to change.
Because I noted this year when you did make that third year in a row double-digit increase. You said, this is unacceptable. On the other hand, you approved it, and somebody asked me why the board did that, and I said, because they had to.
Yes.
There was no other option. Otherwise, the Blue Cross Blue Shield goes under.
I would never approve a 20% rate increase unless I had to. I don't want to do that. I got yelled at by friends, by neighbors. It's painful to people. It crushes family budgets. And we hear it.
Right.
And they're right. So no one's doing that for fun. It's painful for us. It makes you sick. But losing Blue Cross, that's Armageddon. And so we did it. And now we're saying we're not doing it. We're not giving these huge increases. You have to be able to manage closer to Medicare or inflation. And we have to get through this. We have to find some big changes that can keep us going as we fix this. Because it's not going to happen overnight. I would say that we're going to be relying on our healthcare system leaders to do this. That's how it's set up. And we have a lot of really, really good ones. I think they are recognizing, I know they're recognizing, they've said it to me, that the future looks really dim. And that's why they're going to make changes, because they owe that to their community. They have a fiduciary responsibility to their hospitals, to their boards, and to their community to make changes if they're not going to be solvent in the future. So I think they will do it because they recognize they need to. Some will disagree, but there's time, and I think cooler heads will ultimately prevail. So
you're not worried that the whole house of cards has got to fall before people react?
Oh, I worry about that every night. Yes. It's hard to predict how quickly the, quote, house of cards will fall. But when you see these many cracks in the foundation, Blue Cross's situation, Springfield's days cash on hand, community health centers' financial problems, it's hard not to see a lot of cracks. When those cracks yield, I don't know. And no, I really worry about that a lot.
That wraps it up for this edition of 802 News, sponsored by Red Hen Baking Company. Thanks for listening.